Pharmacologic management is crucial in providing adequate pain control in the palliative care patient. So this presentation will discuss the non-pharmacologic techniques that we can employ. We know that pain is serious as a symptom for our patients who are facing life-threatening illness. It can impair function, lead to immobility, cause social isolation, as well as emotional and spiritual distress and suffering. And there are some suggestions that this can also lead to suicidal ideation. So at the end of life, it's crucial that we try all options available. And with complicated pain, this may entail multimodal therapy, various pharmacologic therapies, and non-pharmacologic therapies. And we know that when pain persists, not only are there changes in the nervous system, but that caregivers can become distressed by observing the pain experienced by their loved ones. And this is not just the family member, but it's also the professional caregiver. So for a variety of reasons, we need to use all available treatment options. We also need to think about who's most at risk for undertreatment. We need to think about very young and the older, people who are cognitively impaired, people who are people of color, people who are non-English speaking, people who are long-term survivors, and those who are socioeconomically disadvantaged, the underinsured, or people with addictive disease. Now, a model that helps us to understand how non-pharmacologic therapies might be helpful is a model that I find very useful as I'm interviewing people with pain and trying to explore possible options for treatment. The biopsychosocial model incorporates biologic changes, psychological factors, and social factors. We understand the biologic factors, changes that are going on in the nervous system, maybe from treatment, maybe from the tumor. But in terms of the psychological factors, we need to consider the role of anxiety and anger and depression, sleep disorders, the existential distress that the person with palliative care is facing. We also need to think about the support issues, the social factors, finances, and pre-existing substance use. And as we assess pain, we need to think more than just the location or the intensity. We also need to think about the quality of the pain, what makes it better, what makes it worse, as well as what other treatments have been tried, what's currently being used, what's been used in the past, what side effects did patients have, what are the functional changes that patients experience as a result of the change, and also what about substance use issues, the patient's history, both past and present, issues within the family, as well as other risk factors for aberrant use or potential diversion of the drugs. And as we think about that biopsychosocial model, it makes very obvious sense that we would think about non-pharmacologic strategies. And these are generally categorized into three broad areas: physical, which might include rehabilitation, exercise, physical therapy, occupational therapy, heat or cold, and for some, transcutaneous electrical nerve stimulation. There's a very strong movement right now to provide rehabilitation programs for people with advanced disease. Our physical medicine and rehab physicians and their colleagues in physical therapy and occupational therapy are experts at improving musculoskeletal function. Many of our patients in palliative care experience joint pain, for example, simply because of disuse. They've been so ill that they've not been able to walk or move other joints. And by getting them to move those joints, either through passive or active range of motion, we see resolution of much of that joint pain. That's just one simple example. Psychological therapies Things like cognitive behavioral techniques address anxiety, depression, and the existential concerns of people facing the end of life. Relaxation techniques can be very helpful. Meditation and mindfulness has become a very important addition to our armamentarium. For some, hypnosis can be helpful. Music therapy has been studied and in several populations of patients has been shown to be useful in relieving both acute and chronic pain, as well as the acute exacerbations experienced by people with chronic pain syndromes. Biofeedback can be helpful to teach patients about muscle tightening and tension and ways to allow their own strategies to reduce some of that tension. And in some cases, through the guidance of therapists, systematic desensitization can be of benefit. And then we have complementary and integrative kinds of techniques, things like acupuncture, qigong, therapeutic massage, Reiki. And we have other therapies that kind of cross all of these three strategies. I think of yoga, which is so beneficial, and even for very ill patients, there is a chair yoga technique that can be done. So even if they can't get into some of the positions like downward facing dog, they can do other kinds of techniques while sitting in a chair or sitting on a mat on the floor. These non-pharmacologic therapies are often underlooked in the inpatient and community dwelling kinds of settings, but more and more institutions are incorporating these kinds of techniques for the advantage of our patients, and I would also argue for the advantage of caregivers, loved ones, as well as professional caretakers. When we think about non-pharmacologic techniques, we also think about interventional procedures. And this is where we would incorporate the kinds of strategies employed by our anesthesia colleagues, our interventional radiology colleagues, and others. These might include nerve blocks, vertebroplasty, or other neuroablative procedures where nerve roots or nerve plexes can be quieted, if you will. The nerve roots emanating from those areas be given local anesthetic type drugs and sometimes corticosteroids, and in some cases they might actually be totally disabled through the injection of phenol or alcohol or other lytic substances. For people with cancer, we may think about anti-cancer therapies. Radiation therapy in most centers is primarily being given for palliative purposes, to reduce tumor bulk, to reduce, for example, the size of that bone metastasis, reducing the pain. In some cases, chemotherapy might be helpful. Again, depending upon goals of care and timing within the patient's course of illness, bisphosphonate might be helpful to relieve pain associated with bony lesions, and for some it may also prevent the development of additional skeletal lesions. Octreotide is a somatostatin analog that can be given for patients with partial or complete bowel obstruction who are experiencing cramping and nausea and vomiting due to excess secretions. And in some cases, interventional techniques such as surgery to place stents can be helpful to open up the ureters, for example, to prevent some of the colicky pain that we see with hydronephrosis. Again, we need to weigh the goals of care for that individual patient with the burden that might be presented with any of these kinds of therapies. So we've quickly reviewed some of the pharmacologic therapies that can be helpful in palliative care. They play an important role as we're attempting to improve pain control for people with life-threatening illness.